big mode. Hold on. We're gonna advance because you got that mix.
All right.
Okay.
And can I advance using the?
Jennifer's like,
Yeah.
"No, it's here."
Well, welcome, everybody. Have we confirmed that everybody can hear us? Like Susan,
Susan,
when
you
you're
heard
in your
us all.
office, can you hear
I
us?
can hear.
Okay, perfect. So I'm assuming that I'm not talking to a muted computer.
Come down.
I welcome everyone to a startup meeting for what I think will be a really exciting and very informative trial. It's going to have benefits for many years to come in terms of what we learn, what we discover. And it's a study that's looking specifically at the identification of biomarkers that correlate with and predict audiologic outcomes among children with either symptomatic or asymptomatic congenital cytomegalovirus infection.
It's down.
I did. Up here, man. Okay, I need to click on it, I think. Perfect. And this background information is something you all are very familiar with already, I know. The Collaborative Antiviral Study Group for many decades now has been evaluating antiviral therapeutics in children with congenital cytomegalovirus infection, virtually all of them with symptomatic congenital CMV disease. We initially looked at intravenous ganciclovir at 2 different doses in the 1980s, found the dose that, I'm gonna need to do that, I guess. Found the dose that did correlate with good virologic response, and we took that into a study in the 1990s of 6 weeks of therapy versus no treatment. Then in the 2000s, we did 6 weeks of therapy using mostly oral valganciclovir, some IV ganciclovir to figure out what the dose of Valgan should be. And then ultimately in the 2010s, the 6 weeks versus 6 month study that's called the Collaborative Antiviral Study Group 112 study. And again, all of these were in neonates and infants with symptomatic congenital CMV disease. And importantly, all of them also required antiviral therapy to be initiated within the first month of life. A recent study, this is the 160095 study, was evaluating treatment of babies with asymptomatic congenital CMV infection. Many of you all participated in that study. You remember that it was a pretty massive screening effort to identify the 0.5% or so of babies who are asymptomatically infected with congenital CMV. You wouldn't know that they're infected unless you were doing a screening, widespread screening type of approach. We identified subjects and enrolled them on. We ultimately had 7 subjects enrolled, and of those 7 subjects, 3 developed grade 3 neutropenia. That means an absolute neutrophil count per the Division of AIDS toxicity tables that we used. It means an ANC between 400 to less than 600. And this number, this 43% or so of all subjects enrolled up to that point, met a halting rule for the study. And as a consequence, we shut the trial down. Now, we were fortunate in that NIH, is a strong partner in seeking to advance the management and the knowledge of how to approach treating babies with congenital CMV disease. And they have allowed us to take some of the funds that were in that contract for the asymptomatic study and to develop this biomarker study, which is what we're going to be talking about. Now, the rationale for this is that, both ganciclovir and valganciclovir are harsh drugs. In vitro, they have carcinogenic and mutagenic properties. They've been teratogenic in some animal models. That's never been documented in humans. None of those 3 things are. But we certainly know that they cause significant neutropenia. Anywhere from 20% up to 65% of infants getting either ganciclovir or valganciclovir will develop grade 3 or grade 4 neutropenia. And so you got to think about the risk versus benefit ratio. And if you're looking at babies with symptomatic disease, where the likelihood that they're going to have audiologic abnormalities, or they're going to have developmental abnormalities is quite high, then you can tolerate a more toxic drug because the risk benefit, can still be favorable or favoring use of the drug in a clinical trial setting. On the other hand, if you're dealing with asymptomatically infected babies, that's a different matter because for them, 85% or so, maybe 90% will have no problems at all. They're not going to have hearing loss at any point. And so seeing grade 3 neutropenia in 3 out of 7 was a problem for us. That's the reason we had shut down, as I mentioned on the prior slide. But what it really illustrated is that in order to be able to move this forward, we need to better identify who is at higher risk, especially for the asymptomatics, which are at higher risk of having hearing loss, because that then impacts the risk-benefit assessment that I was just mentioning. And that's important as well. You can't simply focus on the symptomatics because approximately 70% of CMV-associated hearing loss is in the asymptomatic patient population. So the rationale of this study is that we are seeking to identify a subset of infants with asymptomatic congenital CMV infection and also symptomatic congenital CMV infection at increased risk of sensorineural hearing loss. That then will be informative for the design and conduct of future controlled clinical trials of antiviral therapies, and will allow for hopefully smaller sample sizes as well. So it not only can impact the rationale or the reason for doing such a study, a future study, but it also will allow for the design of those studies to be more efficient, because it's more likely that every subject coming onto the trial identified by this yet to be determined biomarker, or biomarkers plural, will be at higher risk. So this study seeks to identify one or more biomarkers to identify that subset of patients at higher risk of congenital CMV. And we're really building as well on some substantial work that Asun Maheas and colleagues at Nationwide Children's, who are collaborating on this study closely with us, have already done with respect to host transcriptomic advancements. And if you want to read a really elegant study, read Asun's manuscript in Nature on this, or Science on this, I think it's where they've identified 92% with 92% accuracy, using 7, I believe, transcriptomic signals, which infants are more likely to develop sensorineural hearing loss. And this is going to be one of the endpoints, the primary endpoint for our study. The objectives are to identify one or more biomarkers that predict audiologic outcomes in patients with congenital cytomegalovirus infection using clinical, virologic, immunologic, and host transcriptomic assessments. Secondary objectives are to identify one or more biomarkers that predict developmental outcomes using those same kinds of parameters: clinical, virologic, immunologic, host transcriptomic. We also are seeking to quantify the extent of laboratory abnormalities in patients with clinically inapparent congenital CMV. In other words, the asymptomatically infected patient. One of the standing questions is, if you identify someone who is asymptomatically infected with congenital CMV, what do you need to do? Do you need to get a sonogram of their head? Do you need to look for thrombocytopenia? Do you need to look for hyperbilirubinemia? Or do you need to do nothing at all and simply follow them over time? So this study will be able to address that very important question as well. We want to quantify the radiographic abnormalities with asymptomatic congenital CMV, do a better job of being able to demonstrate that. We are as well. How do I move this, Joe?
Click on that, like, yeah.
Here?
Yeah, oh, down here.
Here?
Yeah. Move the whole thing up. Flat.
Oh, I'm doing
There you go.
Define audiologic outcomes among patients with congenital CMV in a screened population and a referred population. More on that on a subsequent slide. Essentially, screened population more or less equates to asymptomatics. Referred population more or less equates to symptomatics. And we want to define developmental outcomes in those same things, same groups, screened versus referred populations. Inclusion and exclusion criteria are really very simple. Of course, you got to sign informed consent. You need to be under 30 days or under, I should say, of life at the time you test positive virologically for CMV. That would be by saliva, blood, or urine, and it would be by PCR most likely, but also culture, standard viral culture or shell viral culture would be possibilities. And you need for the baby to weigh 500 grams or more. Exclusion criteria or imminent demise, or in the judgment of y'all, whether there'd be unacceptable risk or it might interfere with, they might have situations that interfere with successful completion of the study. One point I want to make here as well is that this is not a treatment study. And what y'all decide to do clinically in terms of treating your patient who happens to be a subject on this study is completely your call. Subjects can be on therapy. There is nothing in the protocol that says otherwise, and that's by design. I'll also mention that I was on a call, an informal call with the FDA back in June about congenital CMV. It was not about this study in particular, but I did mention this biomarker study that was in development at the time, and they were strongly supportive of this, because they want the same sort of things that we want in terms of identifying potential tests that can be used to better identify those subjects that are at higher risk. And as a result of that, they actually were the ones who said, we really would encourage y'all to be able to have patients who are getting treated or not getting treated and not do it in a controlled fashion. So I think we are developing something that I think will advance the field if we enroll well on it. But also it may advance some of the agency's concerns and issues with respect to bringing licensed indications for drugs such as valganciclovir or letermovir or others. Hold on. Okay, Joe, what did I do? Going the wrong way.
Yeah, click on this, slide this up, and then go back previous.
All right, now let's see if I can do this the right way. All right, so let's talk a little about the study design. I mentioned different populations, a screened population and a referred population. There also is something we call a retrospective population. Let's work our way through that. The screened population are those babies who will be identified through a study-supported salivary screening test mechanism, whereby they will provide screening-informed consent. A buccal swab will be collected with saturated with saliva, sent to a lab here at UAB, a research lab at UAB, where PCR will be done on that swab. And then the results will come back to you, and you'll be able to then follow with the baby at that point, or the family at that point, and say, all right, they've tested positive for CMV. Now do y'all want to be involved in this biomarker study and be plugged in with people that are among the world's experts with respect to congenital CMV, be able to answer those questions and so forth that parents may have. I would anticipate that virtually all of these in the screened population will be asymptomatically infected. They're being screened. In other words, so if you had a clinical reason to test them, that wouldn't really fall into the screened population kind of approach. And we have estimated that maybe about 41 subjects in that screened population are anticipated to enroll. There is a referred population as well, and this has been a challenge on some of our pretty much all of our earlier congenital CMV studies, whereby you might get a patient referred in from a state, one or two over from where you are, or within your own state, or maybe even within your own medical center, and they've already been found to have congenital CMV during their clinical workup, and they're being sent to you for, education of the parents, for determination about treatment and so on. So these are, and they're allowed to enroll in this study. They are anticipated to be symptomatic. I think that's why they're being referred. And we anticipate 44 such subjects enrolling on the study. And then there's a third group that really won't involve anybody on this call. It's a retrospective cohort of Bill Britz here at UAB, working with a collaborator in Brazil. And they have used a screening approach similar to what we're doing in the screened population on the second bullet of this slide to identify Brazilian babies that are born to women who are in a highly seroimmune population. And they are asymptomatic at birth, and they've got radiographic and blood specimens that are available, data from sonograms and clinical specimens in the lab. So they will be able to, at least for some of what we're doing in terms of these biomarkers, be able to be rolled into the effort that we're trying to accomplish here with this study. So I'm going to only now talk about the screened and the referred population. There's a lot of information on this slide. This is essentially taking the schedule of events and putting it into word form. And I'm not going to spend time reading every word on this slide. There are baseline demographics, birth history, labs at baseline, virologic studies obtained at baseline, PBMCs for T-cell responses, as well as whole blood for transcriptomic analysis. The viral load data will be, as stated, you figure out what that baby's blood or urine and saliva viral loads are. And for those that have sufficiently high viral loads, we will do next generation sequencing to be able to identify viral subpopulations. Perhaps it's a viral subpopulation that is a potential correlate for increased risk of sensory neural hearing loss as an example. We have not looked yet at T-cell responses, cell-mediated immune responses. One of our collaborators from a few years ago, Concetta Marseco from Italy, has done a small study in Italy whereby she found that good T-cell responses correlated with less audiologic sequelae from congenital CMV. Whether we find the same thing or not, I think with our larger sample sizes will be something that will be an interesting aspect of this study. And then I've already mentioned Asun's transcriptomic work, and we will be a conduit for getting specimens to her at 2 different time points. And we'll also be doing those 2 time points for the PBMC T-cell responses as well, so we can see what the changes are over time for those 2 parameters. And I'll say as well, before I leave that particular comment about the T-cell responses, we're doing a T-spot CMV test on this, working with Oxford Immunotech for them to supply those kits for us to be able to do those assessments. Subjects will be followed at day 30 and then at month 6 and month 3 and month 6 and every 6 months thereafter. At day 30 and months 3 and 6, growth parameters will be obtained and saliva and urine obtained for those subpopulation assessments and viral load assessments. Physical exam on day 1 and day 30. At month 6, there'll be another blood for viral load and viral subpopulations, and then also, again, the T-spot CMV and the transcriptomic work. Between the first or during the first month of life as well, an ophthalmologic exam will be done, a hearing assessment, the initial audiologic ABR will be performed, neuroimaging will be performed. And then between days 1 and 30 as well, moms will have blood drawn specifically for, and get urine and saliva as well, specifically to look for not only their own maternal T-cell responses as determined by the T-spot CMV, but also to do avidity testing. Perhaps we will find, for example, that women with high avidity IgG are less likely to have a baby with congenital with sequelae of congenital CMV, whereas it's women with low avidity who are more likely to have problems, or a baby who has problems with hearing, or it could be the inverse. I could hypothesize that it could be either of those in terms of what we may or may not find. Hearing assessments are followed clinically, per standard of care, and this interval that I have here that looks like a lot, 3, 6, 12, 18, 24, and on out from there, is actually what the AAP recommends in their Healthy Children's document for how to follow hearing in babies with congenital CMV infection or disease. And then neurodevelopmental testing will be performed annually for the first 3 years, 12, 24, and 36 months. Any kind of laboratory assessments or neuroimaging that's done outside of a window will also be swept into the database as well. Now, this is an important issue on this slide. In most of our studies, virtually all I can think of, we enroll up to a point and then halt enrollment so that we have enough time during the period that we're conducting the study to be able to follow all of the subjects for at least time point X, a year, 2 years, whatever it may be. In this particular trial, we are not going to do that. We are going to keep enrolling until right near the very end of the study. And that means that the subjects that are enrolled early might have been followed for a full 4 years, whereas subjects enrolled a little bit later might only make it to the 3-year mark, and those that are enrolled near the very end might only make it to the 1 month or 6 month or 3 month mark. And we're going to be able to look at this from a statistical standpoint, where we can use the maximum amount of data and therefore maximally use the time in front of us to be able to get the kind of numbers that will be most informative as we seek to identify one or more biomarkers. This is the schedule of events. You can see that probably you can't read it. And so what I've done on the next slides is break it into 2. But this is the layout that you'll see in the protocol itself, and I think in the MOP as well. But if you break it into sections, first of all, I'm going to point out that we're going to have some green font, and that pertains only to the screen population, that group where you're getting a screening informed consent, you're actually collecting saliva, sending it to us, we run it for DNA, for the CMV DNA and so forth. It does not apply to the referred population. Everything else that's not in green font applies to both screened and referred. There will be some blue font as well. That's the audiologic row, I believe. And that's what's standard of care, where we capture the data on the case report forms. But since it's not being obtained for study purposes, we have less control over when it's done. And therefore, if it's not actually reported or noted on or obtained clinically, I should say, and therefore that's reported that way on the case report form, you will not be dinged with a protocol deviation because it's not a formal activity that's required by the research protocol. We expect we're going to get a lot of them, and I don't think we'll have many that are missed. But we don't want to ding you for something you're not solely in control of. And then the black fonts, everything else that is being done for research purposes. So let's look at this a little bit. We have the green screening informed consent under the screening column, which is the second from left. Collection of the saliva, the swab being sent here for the PCR. If it's positive, or if you have a child that's being referred in, you would get consent for the biomarker study. You collect the baseline demographics and hematology labs and chemistry labs. Do a physical on day 1 and day 30, the ophthalmologic exam anytime during that first month following. And I should say that study day 1 is the day that they sign their informed consent for the biomarker study. So it doesn't it won't probably correlate with day 1 of life. And then growth parameters over the first 6 months, hearing assessments at that frequency of interval that I mentioned already. Neuroimaging will be obtained across that first month or so. Viral load from the blood of the infant will be obtained at 1 month and 6 months. And you can see up as well up the second or third, I guess second row from the top shows what the windows are. And we tried to make pretty wide windows to have it relatively easy to schedule these follow-up visits. And then saliva and urine will be collected at not only the 1 and 6 months, but also at day 1 and month 6, but also at month 1 and month 3, because that didn't require a stick. And so we can pretty easily put a bag on and try to get urine. We don't ding you if you don't get the urine, but we would like to get saliva during those times. And then continuing on, we have the infant viral subpopulation assessment. So this is taking the viral load, the blood viral load on study day 1 or study month 6, or taking the viral load from urine or saliva at any of the first 4 time points across through study month 6. And if the viral load is high enough, then we will do next-gen sequencing to better characterize what subpopulations are there. Getting blood on mom in that first month of life, or first month following enrollment, rather, for looking at her viral subpopulations, and then 2 rows below that, also her own T-spot CMV cell-mediated responses. The infant cell-mediated responses will be on day 1 and month 6. Whole blood for transcriptomics, which will route up to Soon's lab, will be at day 1 and month 6. We'll be doing developmental assessments at 1 year, 2 years, and 3 years. And then you can see recording of interval findings as well. Things that are happening between study visits will be have a place in the case report forms to be able to look at those. Now, in terms of the footnotes to these things, they're rather numerous. See if I can advance here. And you can kind of read down here. One thing I want to go to, there was a question in the chat about the imaging for the head, and I think that is down.
Yeah.
There we are, letter M. MRI without sedation is preferred. Head ultrasound is acceptable. And keywords there are without sedation for the MRI. So if it's something that y'all can do, MRI would be better, and we'll pay for it that way. But head ultrasound would be also acceptable. And then if there's additional imaging that's needed, that'll be followed for clinical reasons as well. And we can talk about any of these additional items as we get to that.
I'll go over some.
So Jill will be talking some as well. You up next?
Yes.
Okay, now
So let's click that. Thank you.
we click right here, Susan?
Yes.
Yes, thank you.
Oh, that's cool. Okay. We did some sort of a hyperlink. These slides are not all in one slide deck. So Susan has hyperlinked separate slide decks at the end so we can move seamlessly from one to the other. That's pretty cool. All right, Jill, it's all yours.
All right, I'm sorry. All right, so the next thing that we're going to go over is the clinical operations, which go a little bit more detailed about the items that David just went over on the schedule of events. All right, so these are the things that I'm going to kind of go over in my presentation, and we'll kind of hit those at a high level. Again, the details will be included in the manual of procedure, so we're going to kind of go at a high level. Just as a reminder, as what David just mentioned to you, we've got the 3 different study populations. 2 of them that primarily referred are concerning for you guys are going to be the screening population and the referred population. David has already mentioned the differences between those. Screening is going to have a screening that's going to be done at birth, very similar to what we were doing in the 95 study when you guys were getting them to sign the screening and informed consent, collecting a sample and sending it to UAB. We will only be collecting 1 sample in this study versus like in the previous study. I know we had to do 2 salivas and a urine, so we're only doing 1 saliva sample. And then they're going to have to be enrolled before their 30th birthday of life. The weight enrollment is still the same. And again, as David has already said, we're going to try to project 41 subjects.
Jill, sorry, Jill, but we're still seeing the same slide that David left off with a thank you on it. You might want to change the share to.
So it didn't share it.
So it moved to the next one, which is good. But
Yeah, it didn't. So I guess our hyperlink thing didn't work, but we were all excited about.
Maybe you just have to stop share and then share again whatever you're seeing.
Yeah, we thought we were really doing an excellent thing here, but I guess it didn't work. Yeah, it didn't, our little link didn't work. So sorry about that, guys.
Can you now see a slide with the
The agenda?
agenda?
Yes, the
Oh,
agenda, yes.
all right, so
Okay.
just one extra step.
All right, one extra step then. Like I said, we thought we had made advancement in technology. All right, so you guys were hearing me talk and didn't see all of that, but this is a slide that I was reviewing, referring to it just a few minutes ago. So basically, like I said, this slide is talks about the differences in the enrollment categories. And as David has already mentioned, the referred population, as like I said, it's going to be found through your clinical workup, referred to your site. They must have still, though, a positive CMV by culture PCR shell vial that was done on or before the 30th day of life. So you will need documentation of that to enroll the subject into the EDS system. All right. So as we always talk about, we know we've got the pre-screen failures and the screen failures, and we always like to try to point that out, the differences between the two. Pre-screen failures are subjects that did not sign your consent, either your screening or your biomarker. You approached them, you talked to them, you had conversation with them, and family decided they didn't want to enroll in the study. They did not sign your consent. Those are going to be listed as your pre-screen failures. You will be entering that data in on a monthly basis, very similar to those sites that have participated with us in the past, as what you're doing with our other studies. For our two new sites, it's something that may be a little bit new for you, and we can definitely walk you through that process as we get your sites up and going. A screen failure. A screen failure is going to be any subject that actually signed a consent form, but they may have withdrawn prior to you actually getting a ID number or into the system. So these are ones that you talk to, parents signed consent, but at some point they said, I changed my mind, I don't want to do it. So those are going to be no longer participating as well. All right. Referred population. So I got a question, say, is there an age cutoff for the referred population? They have to be enrolled and diagnosed for 30 days of life as well. All right. Enrollment will occur through the EDS, electronic data entry system, that's going to be located on the School of Public Health website. Chi-Chi is going to go over a little bit of that information as well today, and then we're going to kind of go, we'll have separate training that will be recorded. At least one person at each site must have access to the EDS system in order to enter the data into the system. And it's password protected, and it does require training in order for you to gain that access to the system. So in order to know that, and I know Susan's going to mention this as well, we will need a contact sheet from each one of your sites. And on that contact sheet, we need you to identify who will be needing access to the EDS system.
Jill, can I interrupt for just one
Yes.
sec? I may have misheard, and I did not read carefully the chat question. For the screened population, they have to enroll by 30 days of life. So they have to be enrolled within those first 30 days, because that's when you have to virologically confirm that they have CMV. For the referred population, they have to have been virologically confirmed within the first 30 days, but they do not have to enroll within that first month of life. You know, we don't want them to enroll at 6 years of age, but we don't have a window in there as long as the referred group has already been virologically confirmed within that first month of life.
And that answers that second question that Maria has up there. But if they were diagnosed for 30 days and referred at 6 months, are they still eligible?
They are, but well, yes, they are, because we may not have as much good information on the like the T-spot CMV or the transcriptomic, because that's anticipated to be right shortly after birth, when that's going to be most meaningful. But we don't have a criteria against it. And as FDA had commented at the June informal call that I had with them, the more data we get, the better. So we are not forbidding that. That's correct. Right.
And then can screening be performed at a newborn clinic rather than at a birth hospital?
There is nothing about it being in the birth hospital.
That's correct.
We took that wording was intended with the asymptomatic treatment study to be helpful, and it
turned out to be
restrictive.
Right.
So
it turned out to be restrictive. So
we did away with that.
Right. We did away with that. All right, so the screening saliva sample for those that are in the screening population only, very similar to what you guys are familiar with doing, the ones that participated in 95. You're going to be collecting a swab that's going to be stored at room temperature until it's used. You want to make sure that you don't collect your sample within 30 minutes of a subject breastfeeding because you don't want to actually get the breast milk on the sample, on the swab itself. You want to obtain the sample from under the tongue. You want to insert the swab into the kind of like into the cheek area, generally rotate it for about 15 to 20 seconds, more the better. The goal is basically to soak your swab up with saliva because as we know, newborns' mouths are a little bit more drier than older infants. You're going to remove that swab, place it in the vial, break off the shaft and label it, and then store it at room temperature or 4 degrees until shipped. We did not put in the 4-day restriction as well that we learned from 95. So that is not in this protocol as well. So you did not hear me say that. You got to ship it within 4 days. All right. This is going to be the address that you're going to be sending your screening saliva shipment to. And it's going to be Misty Person, which is again the same address we were utilizing for our 95 study. Once you've got your positive for the screening subjects, you've got a positive result from Misty's lab, or your referred subjects, you got a positive from clinical lab, they are eligible for the enrollment into the biomarker study, a main study. They must have, everyone must sign a main study ICF. And then at that point, you will go through this, they will follow the exact same schedule of events throughout the duration of the study. This is again just the schedule of events. You've already seen it once, so we'll just kind of go and break it down just a little bit further for you. All right, so for your virologic samples, this is for the baby. David has already gone over these as well. You got your saliva done on days 1 and 30 and months 3 and 6, and you can store those at -70 or colder until you're ready to ship. You've got your urine also that you're going to be collecting the same time periods. And as David has already mentioned, no deviation is required if it's not collected. You got a blood sample, that's a 1 milliliter collection on days 1 and month 6, and it's whole blood, and again, stored until you ship. Your transcriptomics on days 1 and 6, it also is a whole blood. It's going to be collected in a Tempest tube that we will be providing to you. And then it's stored, it must be stored within 12 hours of collecting it until you ship it at -20 to -8 until you can ship it. So again, your saliva, urine, your whole blood for transcriptomics and viral loads can all be batch shipped to UAB together. The infant T-spot or T-cell response, which is 2 milliliters, done on days 1 and month 6, are going to be stored 18 to 25 until you ship it, and it must be shipped on the day of collection to your Oxford Immunotech lab. We do have some enrollment weight limits down here based off of the baby's age at weight because of the blood out concern. So if their weight is going to be between 500 and 699, you're only going to get the transcriptomics. If it's between 700 and 1349 grams, you're going to get the transcriptomic and the blood for the CMV viral load. Between 1350 and 1849, you're going to get transcriptomics, blood for viral load, and T response. And if they're over 1850 grams, you collect everything. So you kind of got a higher kind of scale of how you're going to be collecting as well. Now for your mother, you're also going to be getting blood for next gen sequencing on between days 1 and 30. It's going to be 3 mils stored until you're ready to ship it to UAB. Urine and saliva, store that and ship that to UAB as well. Your maternal T-cell responses or T-spot, 12 milliliters whole blood. Again, that's going to be shipped on the day of collection to your Oxford Immunotech lab. And then the maternal CMV IgG avidity, that is to be determined. We've got information that we're still trying to gather on that one. This is the Oxford Immunotech lab shipping address, and again, it will be in your manual of procedures as well. Your hearing exams, as David has already mentioned, is considered standard of care. You got your time points here. Data will be recorded in the EDS. And most important is a copy of the de-identified grafts and traces will be sent to me at the central unit, and this is my address there. Same thing with the ophthalmology exams. If they are referred population, it's considered standard of care. If they are screening, of course, you're going to be getting it for the study. You've got a window between day 1 and day 30. Any abnormal findings will be followed as standard of care. Capture the data, send a copy of the de-identified results to me at the central unit. Neuroimaging, same thing, done as standard of care for the referred, done strictly for the study. For the screen population, same window. David's already mentioned about the MRI without sedation preferred, but cranial ultrasound is acceptable. Abnormal findings will be followed as standard of care, capture the results, and then send a copy of the de-identified results to me at the central unit. Developmental exam, we're going to be doing at months 12, 24, and 36, utilizing the Bailey Scales of Infant and Toddler Development 3. Again, capture those results in the EDS system. We're going to have a form for that to be captured. You've got your growth parameters. That's going to be done on days 1 and days 30, months 3 and 6. And basically, you're going to be doing length, weight, and head circumference. You've got a very limited targeted physical exam done on days 1 and 30, looking at the skin for a petechial and jaundice, and the abdomen for hepatosplenomegaly. Your hematology is going to be done on day 1. It's going to be 1/2 ml of blood done in your local lab. WBC with diff, hemoglobin, hematocrit, platelet, and record any values that are going to be done over the 48 months time period that they're in the follow-up phase. We're going to be capturing those, as David has already mentioned as well. Chemistry on day 1, you got 1 milliliter of blood, also done in your local lab. ALT, direct bilirubin, and capturing those labs throughout the course of the 48 months follow-up. Any protocol deviations that you will be doing for anything with the exception of urine, both subject and mom, and hearing exams. Anything else that's not done as outlined in the schedule of events is considered a protocol deviation. And I know David used the word deem. I don't like to use the word deem. I like to use the word document. So it's a different kind of D. And the reason why it's important is 5 or 7 years from now, when we're trying to write this study up and we're trying to put it all back together, we won't remember what you told us. So if you have it written out in a protocol deviation form, that may clue us that, oh yeah, this is why we don't have this particular data point. So if you don't get the urine or the hearing exam, that is not a protocol deviation. Anything else that you don't get as scheduler on the schedule of events, that will be considered a protocol deviation. And of course, you got my number. I think I've kind of communicated with the majority of everyone already, but you've got my contact information here. Should you have any questions for me regarding how to manage the study clinically, I am available both phone and email. Any additional questions on clinical operations? And the manual of procedures will provide in more detail as well. So knowing I've got to do my stop sharing. Yeah.
And now do
I gotta do a new share.
that's a share.
Yeah. That's what I said. Okay, we're trying to get Jennifer's slides up.
Go to yours and do the link.
Right here.
Yeah, well, just open yours, whichever, where you could, don't worry about sharing them, just open them.
Oh, okay.
And that's fine, I guess. So you can
I think we're all the same, but the thing, thank you.
And then go to the end of yours.
Okay. First and last. How's it work? Well,
Susan, can you find the folder for us?
Here it is. It's right here. It is.
Okay, good.
We just have to do it that way.
That's fine.
Yeah. Where's Jennifer's folder? Let me close your background out.
Here, up top, go back to the thing, to the PowerPoint.
To the PowerPoint.
Share.
No, I think this.
Sorry, guys, bear with us for a second. We're trying to work with the technology.
We should have just did it the way we normally do. No, it's not.
We have the file open on the screen here, but there's not an option to share it.
But what about share screen right down there, the green one?
We hitting that, but that's what comes up.
And there's
Click on
no,
that, click on that.
I did.
Now share, share,
Okay,
share
now.
new share.
Let's see if you can see. Are you seeing Jennifer's slides?
We can see it now.
Okay, you seeing Jennifer's slides? Okay, there we go. We got the new share button. There we go. Okay,
but we need to open this up in a
yeah,
presentation.
in a presentation mode. So move that little floating control at the bottom.
Go here, grab it, right here, grab it, pull up.
Yeah.
Now go to here. One more.
Okay, and I got something in the chat. What's that in the chat? That shit. Okay, so if we enroll a subject referred to age 6 months, who is virologic confirmed congenital CMV, but missed some of the early data points, they got documentation of protocol deviations.
No, because day one is the day they enroll. So in that case, the study day one, T-spot CMV or study day one transcriptomic sample in the Tempest tube will still be considered per protocol as day one. The problem is that it's in a 6-month-old child, not a neonate. And that's where there's a bit of discrepancy, but we didn't want to be too restrictive, because if we set it where you had to get a referred subject in by 2 months, for instance, what if they come in at 2 months and 2 days, and so the idea is to get them in as soon as possible, but just enroll them if you can. If it's a 4-year-old, that probably is one we want to let go, but within reason, if they're still little and riding in a car seat or whatever, however you want to define it, that I think would be would be a subject we want.
Good to know. Do we need to get your approval to enroll a referred congenital CMV patient? Is there suggested upward age?
I don't want to put a barrier for y'all. We all know these studies are hard to enroll. And with the exception of the 112 study, they all run long in terms of trying to get people on, and we don't want to add more barriers for you or complications for you. On the other hand, we are here at any time. And so if you do have a question, if you're not quite sure if it makes sense, do reach out to Jill or me, and we'll try to help you walk through that. But if your judgment is, hey, look, they're 3 months old, I want to know what's happening with this baby, I think it would help our study, our being all of us, because it is all of our study, then go ahead and enroll them. And we'll just, we might not be able to analyze them if it's I'm making this up, a 5-month-old. Maybe we find out that that's just not likely to be that meaningful for one of the biomarker assessments, but we still could get subpopulation data, viral subpopulation data. Then, we're kind of sweeping everything up that we can in this particular protocol.
But great questions. All right, Jennifer is going to go over with the laboratory.
Hi, everybody. So I'm just going to let you know about the lab supplies that the central unit is providing for the study. Do I need to?
Should be over there.
Okay. So for the buccal swab screening, you're going to get a box of polyester tip swabs, 100 swabs, and a couple bags of these 4 ml vials, which you're gonna put the swabs in. So it's gonna be basically what we call a dry swab. There's no transport media in those. And these, like Jill said, will be shipped to Misty Purser at this address.
Yeah, it should be.
Oh.
Oops. Yeah. Okay, so the viral load supplies are going to include, for the infant, it's going to be the EDTA microtainer tube, the urine collection bags, the swab kits for with UTM for the buccal. That's going to be the same for the mom and the baby. And then the mom will have the EDTA, regular size adult EDTA tubes, urine collection cup for the mom, and the cryo vials for the aliquots of the blood and the urine. And specimen labels. Supplies for the other labs that Jill has already mentioned, the T-Spot. I believe we'll be supplying the collection tubes.
Yes, yes.
And then as Jill mentioned, you will be sending those straight to the Oxford Immunotech lab. For the maternal IgG avidity, that's still up in the air, so we'll let you know what happens with that. The Tempest tubes for the transcriptomic analysis will be provided by the Nationwide hospital lab, and then you will ship those to us, and we will ship them back to Nationwide periodically. Next, okay. So just a few things that I've learned over the years that will help the lab. Please, of course, label the samples clearly. That helps everybody because there's going to be multiple people inputting the information. And we have to put the information in our computers directly from the specimen, not from your nice printed shipping form. And it's helpful, I also think, to label the aliquot tubes before you put the sample in it, because the temperature may affect that, the label sticking. And if you tape the labels, that kind of, there's a limited space in our storage boxes. And I know it may not seem like a big deal, but when you're storing a lot of samples, it kind of hinders that. And if you need to relabel, same thing, remove the original and replace it with the corrected label. And as far as shipping, please don't tape up the styrofoam cooler. This is also when you're shipping with dry ice against IATA shipping guidelines, and it also makes it difficult for us to get into the package. And most importantly is enclose a signed shipping document. Let's see what questions we have up here. Will the slides be sent to the sites?
Yes, we can send those out, and they'll also be posted on the website. Once we get the website up and posted with this EDS system, we're going to have it posted there as well.
Okay, and let's see, shipping of specimens. So all your virological samples and your transcriptomic samples will be frozen at your site and batch shipped to the UAB Central Unit lab. Specimens should not be shipped on, if they're going to be delivered Saturday, Sunday, or holiday. And since the pandemic, we all know that the shipping companies have been backed up. So in order for it to not get lost and possibly sit on a loading dock over a weekend, I highly recommend shipping Monday through Wednesday. So if it's back, it gets put off one day, we'll at least get it by Friday. And then that's my address to ship it to. That'll be in the MOP and just ship by the IATA guidelines for biological substances. And I think that's it. Does anybody have any questions about lab supplies?
Don't ship priority overnight. We learned that with one of our other studies, just ship a
Right.
standard overnight.
Standard overnight.
Yeah, priority or overnight is about 3 times the cost, and it was
Yeah.
Mary White. It was doing Mary White time, and that probably forced her to retire.
All right. Stop share.
The new share. The new share, is that what you said?
And which one is this?
Regulatory, down at the bottom, on the go to the left.
That one there.
Click the regulatory one over there. Says number. Oh no, it's on
Oh,
the
see.
got it.
On the
Yeah.
side, yeah.
There you go. Now share.
Yeah, this one.
the blue share. Or Susan.
It'll work. Hey, we got it.
Okay, we finally figured it out by the fourth set of slides. All right, Susan, you're up.
Hi, everyone. My name is Susan Branskin, and I'm going to be going over the regulatory portion for you. And I was also going to be joined by Tina Robinson. So Tina and I are both here today. So we're going to be going over our different things. So buckle up. We're going to go real fast because we got 10 minutes. I tried to get them to give me a couple of hours. They wouldn't do it.
You got longer.
So here we go. So first of all, we're going to identify the required essential regulatory documents that are needed. And then we're going to discuss the single IRB process.
Before you get into that, Susan, I've got a question in here about can shipping occur on a Friday or just Monday through Thursday? As Jennifer mentioned, because of the pandemic and the delay in shipping, and some issues with shipping, ideally ship only Monday through Wednesday. Definitely don't ship on Fridays. The lab is not open on the weekends. So to keep the sample from sitting on a loading dock somewhere, and then of course it unthaws and it's no longer any good valid. If you can ship Monday through Wednesday, that would be better. And no holiday arrival. So don't ship on a Friday, on a Wednesday when you know the holiday is going to be on that Thursday, because we observe national holidays. Sorry about that. Okay, go ahead, Susan.
That's okay, that's fine. Okay, so here we go. Here's the gist of the regulatory documents, what's required, and the sources. And the key take home point for this slide, and again, they will be provided to you, is that last bullet and the DMID Chrome's website, which has all of our central regulatory documents and our regulatory file document guidelines and our source document guidelines. That will be listed there. So first we say, we divide it here in the central unit as two different categories, your site-specific documents and your protocol-specific documents. I'm not going to go over that. This is what will be required. We will give you this checklist that will have the site-specific documents on it, and also a checklist that we will have our protocol-specific documents on it. In this, let me go back, in this right here, there is the bottom thing, it says this quality clinical management plan, and at that point, you will be in contact with Tina. Tina will be discussing, if you have your CQMP, let Tina talk about this now.
Hi, this is Tina Robinson. Regarding the clinical management plan, I will reach out to all of you with an email and let you know about the way your site can create this quality plan. It will have the tools inside as well as a sample CQMP. And if you have any questions at all during the process of creating your quality plan, just reach out to me and I'll be more than happy to assist you.
Okay, great. Thank you, Tina. The next thing we want to talk about is our protocol-specific documents. And the protocol-specific documents, this checklist again will be provided to you. I will give you this checklist, and this will only be provided to you as an informational checklist. You do not have to fill it out, but please know that as you're sending the documents in, that we at the central unit will be checking off as it goes. And this is our working document during the process of getting your site activated here. So the minimum required training for this study, as in any other study, the minimum required training, anybody that's going to be listed on your delegation log, regardless of what their study responsibility is going to be, will have to have their good clinical practice and their human subjects protection training. We'll have to, and then in addition to that, we will want to have their source document training, their regulatory document training, and then the EDS training. That's going to be a minimum, that's the minimum required training for the sites. First thing that we're going to do is we're going to send you an investigator of record agreement. This is a non-IND study, so we will not be using a 1572 for this study. We will be using an IOR for this study. And Jill has mentioned that there will be 3 different laboratories that you will be using for this study. These research laboratories will not be listed on your IOR. On your IOR in the bottom, on the bottom first thing, the bottom left-hand corner talks about listing your clinical laboratories. The clinical laboratories will be the laboratories that you're going to be using at your sites. When you put this on here, then I'm going to automatically need your CLIA, CAP, and reference ranges for the research for your clinical labs that you're going to be listed there. And if you look over in the highlighted section on the second page, I need you to add your IRB there. Your IRB will be added at the top of that because they will be doing a review to rely on an outside institution. And the UAB has agreed to be the IRB of record for this single IRB study. So we will be providing you with a blank IOR when we conclude this meeting. So let me talk now to you about the single IRB documents and what's going to be required from the UAB as a single IRB of record for the study. The UAB requires these 3 documents. They require your consent form, tracked and clean. When we send you the consent form, like Jill had mentioned, there will be 2 consent forms. There will be a screening consent form, and there'll be the main study consent form. When we send it to you, keep your track changes on and make the changes to that consent form. The UAB-IRB will be reviewing that. Then in addition to that, we will have a Reliance Agreement. And in addition to that, there'll be the local content information. So each one of your sites, when y'all send me those 3 documents, I have to in return, go and do an individual submission to our IRB with those 3 documents from each one of your sites. So let's go into a little bit more depth about the consent forms. First, we're going to talk about the consent forms. No, you can't read it, but this is what was submitted to our IRB. It is currently at review at our IRB for the study now, and we do not have IRB approval to send these out to the sites yet. We're expecting to have that the first in January 2022, and we'll be sending those out to you shortly. As soon as we get them, we're going to send them out to you. If you notice on the consent forms, there's yellow highlighted areas. On the consent forms, the only changes that you are allowed to make are what's in the yellow highlighted areas. If you do make changes other than in the yellow highlighted areas, it has to be annotated on your local content information sheet that it is required by your local IRB for those changes to be on there. And Jill will be reviewing each one of these consent forms, and she will let you know whether or not that you've done something that's not on the consent form or not on your local content, because we cannot let it go past our office into the UAB IRB knowing that these are their standards. So the first one is the screening. That's what it looks like. The second one is the main consent form. And I'm going to stop right here and ask if Jill's got anything that she wants to add to this part with the consent forms.
I want to just kind of reiterate what you said, Susan. We, in previous studies, we've had a lot of issues where sites will start making changes to the consent form, realize track changes is not on, and then they'll put the track changes on and start making changes afterwards. The IRB will not accept it. They want to see the changes, all changes from the template that's provided to you and with your changes on it. Also, as Susan has already said, your local context form, if it does not include and it doesn't say it's required, we know there's certain things that IRB like, but if it's not required, it won't be accepted. So do not make changes to your consent, because that's something that a lot of times we see like headers. People will add a header on, they'll say that's required, but there's no policies to support it. It's not added in the local context, and so our IRB will not accept it. So make sure if there's any changes that you want in your consent form that's required by your site, make sure you either provide a policy stating that it's required, or you have to have it documented in that local context. Otherwise, we're going to have a lot of back and forth, and it's going to get pretty frustrating for you, because we can't send it forward to the IRB with those changes as you've documented it.
Then I'm going to add to what Jill said too, is whenever you and Jill go back and forth with each other on the consent forms and you have your final version of that consent form and it's ready for me to be submitted to the IRB, please make sure that I'm included in that, because I need that final copy so that I can submit it to the IRB. All right. Next, we're going to talk about, this is what Jill was just talking about, our informed consent process continued. This is the vicious cycle, and it is a vicious cycle, but it will keep going. We're going to, once you receive the consent form from us, you're going to return it back to us for review. Jill's going to, number 2, Jill's going to provide the review. And then number 3, the site will return the final copy after corrections back to us. And then the UAB Central Unit will submit that to the UAB IRB for approval. And then once we get it back, then we're going to send it back to you. Now, at this point, when we send it back to you, remember, The UAB IRB is your IRB. That's your approval. They are serving as your IRB. Your local IRB has deferred that their approval to the UAB IRB. So once you get that approved consent form from the UAB IRB that you're going to use to consent your patients with, make sure you close the loop with your local IRB and provide them a copy of your that approved IRB. Does that make sense? Okay. Next, we're going to talk about what type of agreement. That there's a reliance agreement. This is number 2, item number 2. We need your reliance agreement. Our IRB will.
Can I say something? I just
What,
thought about it.
Jill wants to say something about.
I'm thinking about, we just had a scenario and this just came up. So going back to the informed consent, as Susan mentioned, UAB serves as an IRB of record for this study. So that is the consent form that you're to utilize when you're consenting a subject. We had a situation where a site was utilizing their locally stamped IRB approved consent, and that's not acceptable. So make sure that when you're consenting your subjects, that you're utilizing the consent that has the UAB IRB approval stamp on it. It has an approval date and an expiration date. That is going to be the one that you will be utilizing for this study.
Great.
Sorry about that. I just thought about that.
No, thank you, Jill. So item number 2 that our IRB requires is your reliance agreement. What type of reliance agreement is your site going to use? The good news is there are 9 sites. There are 11 sites participating in this study. 9 of the 11 sites are participating in the Smart IRB Reliance. We have initiated the Smart IRB Reliance for this study. It will not be sent to your IRBs until our IRB issues IRB approval. Once our IRB issues approval for the study, they will finalize this document, push the submit button from their end, and all of your IRBs that are listed here for these 9 sites will receive notification, hey, you are participating in the study and whether or not we will rely on them via Smart IRB Reliance. This is optimal. This is what we want. We want the sites, IRBs, to push the button and say accept, and they will participate in the Smart IRB Reliance for this. No other action is required. However, if your IRB does not want to participate by pushing the button, there are another mechanism in place to do that. It is a 1-page seed letter. The 1-page seed letter is from the Smart IRB, and it's between the 2 institutions saying, yeah, we are a part of the Smart IRB. We are participating, but we don't want to use that online agreement. We want to have our little separate 1-page seed letter. We will use that. Our IRB is used to this, and we will complete this form. If your IRB has another form in addition to this form, then we can do that. That's fine. So for the 2 sites that are not participating in the Smart IRB Reliance, you will have the option to do the IRB authorization agreement. So I know you can't see this, but see how complicated it gets. Then we're going to get into like an agreement type situation, like a contract, if you will, between the IRBs. This sheet has to be completed by your local IRBs. We will provide this agreement. We will send it to you, and you will facilitate that arrangements between you and your IRB. Once we get this signed by your site first on the bottom last page, then I will receive that back. I will put that as a part of your application packet along with your consent form. And then our IRB will issue the final signature on it. Once I return your stamped consent forms, your authorization agreement will also be signed by IRB at the time. So just to recap on this, it's not hard. It looks like it's a little hard, but it's not. They just want to know what type of reliance agreement that your site would like to do to rely on an outside IRB. It's going to be either online, as we mentioned before. You're going to be online, you're going to push that button, or you're going to push that button and you want an extra page, you want an extra 1 page, that'll be fine. Or your IRB is not participating, as in these 2 sites, they're not participating in the online reliance system, and we will have to go back and forth with the alliance agreement. And that's fine. It's just a little bit more time, but we'll take care of it. We can do it. We're used to it. Okay. The next thing that we're going to need then is the local content information form. This is the form that Jill and I was referring to. It's going to be about 4 pages long, and it's going to need to be filled out by your IRB. This statement this form right here is very important, because if you make any changes to the consent form that have the yellow, that are other than what we have highlighted in yellow, it needs to be documented on this form in order for it to be allowed. If your IRB fills this form out and they do hyperlinks to the policies, those hyperlinks must work. Our IRB does not mind clicking on a hyperlink and it going to and opening up. But if your hyperlink doesn't work, say for example, you have a policy like Jill's example was used on having a header and footer. So you have a header and footer and your IRB wants to have it on there and it's a part of their policy number. Make sure that that hyperlink opens up that policy. If it doesn't open up that policy, then you need to provide that policy with it. But hyperlinks are acceptable. So that's the next thing that our IRB would need. Okay, now to summarize it, I'm just going to summarize it and say, after this meeting is over with, this is what we're going to send to you. Well, in addition to this, before I get started, we are going to send you the slides for today. We will send you we will send you all the slides in one PDF today that you'll be able to review. And we'll also have this recording that will be available for you to review. But in addition to that, I'm going to send you the contact information sheet. We're going to send you a half a partial filled out investigator record IOR sheet. I'm going to send you the site specific and the protocol specific documents we just discussed for reference only, just you to look at how hard of a job that we're doing here. Also, I'm going to send you the protocol training log and the other protocol/other training log, because we need you to document this training that you're doing today on this protocol/other training log. So you'll need that log in order to document today's training. Then we will send you upon approval. We're expecting this to be around January. We're hoping it'll be around January. The 3 documents that we discussed that our IRB needs: the consent forms, the local content form, and whatever type of authorization agreement that we're going to do. And we're going to send you your overall project notebook for the study. So we're going to send you that, expect that in February 2022. We still got to send that to the print shop. So we hadn't got that to the print shop yet. Now, what I would like to ask you to send to me after today's meeting is the contact information sheet. We need that back just as quickly as possible so that we can keep the study personnel at your site up to date on all the study. So we've got to know, first of all, we got to know who they are before we can tell them what we need. And then this investigator record agreement, I need you to fill that out as soon as possible and get that back to us too. And the reason that we're doing this is your aha moment with this is because what you put on there, I can go from your other CPIC studies or your other CSG or your other studies that you've been participating with us, and we can pull all of those regulatory site essential documents from that study for you, and you won't have to do that. So, but it's very important that we have that because we need to confirm who your sub-investigators are going to be and who your local lab. And we can pull the CLIA cap and reference ranges from what we already have on file with you. So we'll go and pull all that information, but we need to have these baseline documents to start with. There's the log that I was talking about. Remember to document this log that I will send you as soon as when this is over with. Document today's training. So make sure that you document today's training on your log. Here's my contact information. And again, it'll be on the documents that I send you today. So if anybody had any questions, go ahead and throw that in the chat. I know it's been quick and I know it's a lot of stuff, but please email me with any questions you might have.
All right, let's see here. I'm gonna try to. So we did the advancement, and then we did each year. Are we seeing budget finance on our slides? Is that what you guys are seeing? If anybody can just give me a thumbs up or chat. Okay.
Yes.
All right, perfect, perfect.
Good afternoon. This is Sarah Dowdy. I'm the new Mary Wyatt.
She's a 2021 Mayor
And
White.
have been for a little bit now. And so I just have 3 little slides talking about how we're funding this study. Okay, So two primary people that you'll be in contact with regarding your subcontract and invoicing is, first one is me. I'm your primary financial contact, and that's my email address and my phone number, and I work in David Kimberlin's office directly with the central unit. So I assist the central unit in to plan the site budget. I'm going to facilitate your subcontract. I receive your invoice and make sure they get paid. The other person you're going to be in contact with, or your OSP is Brad Smelzer. He's the one who actually sends the draft subcontract. He negotiates the contract language, like all the other terms, apart from the statement of work and budget. He actually gets the UAB signature. He's not involved with invoicing at all. But those are the two people you are communicating with regarding your subcontract. Okay. So, so just to be clear, this is a contract from NIH. It's not a grant. So you're receiving a subcontract. All existing 0095 sites should have already received 2 amendments. One amendment provided you closeout funds for 0095, and the second amendment provided funding for this study that we're talking about today. The sites who did not participate in 0095 or stopped participating for whatever reason, they'll get a new subcontract just for this study. So the funds for the study, just basic categories, you're going to get some startup funds in the first year. You'll get maintenance funds every year. You'll get funds per patient screened, very similar to 0095. And you'll get funds when you enroll a subject, and those are paid per visit completed. And I think this is my last slide. So invoicing, all invoices come to me. Timeliness matters. I have to document how great a subcontractor you are. And one of those things that I have to document is if you invoice on time and if you invoice appropriately. So I like to say yes to all those questions. And I try to do my best to remind your financial person, your admin, and the PI, hey, let's invoice, let's get our invoicing up to date. So when can you have funds? Your startup and maintenance funds are always tied to your regulatory documents. You know, is your contract executed? Do you have IRB approval? Are your documents up to date? Your screening invoices, just like 0095, we're going to send you monthly screening reports, and you'll use that report to develop an invoice, and so you know how much you can invoice for per screen. And the participant invoices, the per visit invoices, should only be submitted after your data has been entered in the EDS system and your samples have been shipped. Is this my last slide? Yes. So just a word about this funding. This funding was, you know, it is still the same contract that funded the 0095 study, and NIH was allowing us to convert the funds to also pay for this natural history study. So the funds that we have are, it's 5 years of funding. We have a hard stop 5-year end date. The end of this contract is February 28th, 2026. It's really 4.5 years from this past September 1st. So you might, I'm not sure if everyone has seen their new amendments that provide the funds. You'll get so many screens in that amendment. I think it's like 680 screens. We do not necessarily want you to pace yourself with your screening. And David might want to talk about more about this. Some sites are able to screen a lot of babies. Just looking at the 0095 study, we want you to screen as much as possible to find those subjects as quickly as possible. And so our goal is really to do as much as possible early in the early years as we can. But keeping in mind that the study, the funding for this study has a hard stop in February 2026.
And I'll just sort of add to that or reiterate, if we are able, if we have a finite number, when of course we do have a finite number of people that will enroll in the study. If more of those can enroll early in the study, that means we have more data points in terms of follow-up for more of the subjects, which would be good. It's not for us to say how you run your shop in terms of the screening for the screened population. We want to provide you, if you want to enroll, if you want to screen more babies, say in the first year and a half, that would be ideal from our standpoint, because you screen more babies, you identify more babies, and therefore more babies get enrolled in the study. Rather than the opposite of that, which would be say, look, I'm gonna screen the same amount every year for 4 years. Then we, that's another option. And if that's the only way it works for you guys, then that's fine. But the downside of that is the 1 quarter that enroll in year 4 will, by definition, not be able to be followed for very long. So if you're able to really front end, especially the screening part of this, that would be ideal. If not, we'll take what we can get.
Yes, and then just the other thing to note is that your subcontract amendments provide funding, I believe, for 2 years. That's how we're just doing it for now, and then we'll amend those in the following years. And we just did that in case we need to make adjustments to sites or how we're funding sites. So any questions about the budget or how the study is funded or invoicing?
And you are muted, so if you're trying to speak, you have to unmute yourself, or you can put it in the chat box. And while we're doing a transition over, I was just reminded, Jennifer just had a wonderful reminder of some things we've been facing lately with some of our other studies. This goes back to lab supplies. Jennifer's really good about making sure that lab supplies are maintained within a current date. So if you're transitioning off of a study and you've got a new coordinator transitioning on, please make sure you guys are sharing the location of those supplies. Unfortunately, it can get costly. We're having to resupply the same supplies over and over and over to the same site. So just make sure you're having like a transition plan of where those supplies are for the new coordinators that are going to be coming on to the study. Chi, I've got your slides up. I can drive for you if you just tell me next slide.
Yes, okay, thank you. So I'm Chichi Aben, and our group here at School of Public Health Biostatistics Department is in charge of the data management for this study. Some of you have been involved in the CASG or BAA studies with David, have been working with us, although the 0095 was with MS, but it's similar in terms of the system that we're providing. So in this is just an overview. As Jill mentioned a while back, you will be required to at least one in your site who will be in charge of enrolling and entering the data would need to be certified in the data entry system. So the data entry system pretty much would provide you with visit menus so that you would be guided as to what are going to be the forms that are associated with each of the visit. You'll be able to print forms that are updated, so you don't have to print them ahead of time. And if you want to say, okay, I want to print forms for a particular visit, then it's already there with a particular PI, the ID of the patient and the particular visit. So they will be auto-populated. That will make it easier for the form completion if you want to have a worksheet to work on before entering it into the data entry system. There'll be document library where we can provide, documents such as the protocol, most recent versions of the protocols and other documentation that the central unit would want to have available to all the sites. It is secured, password protected. We only assign IDs to the participant. You're not going to be entering any PHI, so we're good. And the IT infrastructure is actually being covered by the UAB Central IT. Next slide, please. So to ensure data quality, as we've already mentioned, we will be providing training as well as certification for those who will be entering the data. So they need to pass certification to be able to get an account and able to enter the data. We will be doing data checks as you move forward and enter the data. There will be ranges and skip patterns within the form to help minimize any data entry error. We will be asking data entry people to actually save so that they don't, they'll be able to work more efficiently and not lose any information that they've already entered. And most importantly, be able to lock the form so that any forms that are unlocked will not be part of the monthly report. But if you have already locked it, then that means that you're telling us that the data that have been entered are complete and you're done with it, and it could be added to the monthly report that we'll be sending out. And that would include as well, from a financial point of view, what have been done by your site. So, however, if there's any changes that need to be made later on, if there's going to be a question from the central unit, you are still able to unlock the form and also override some of these ranges that we have available, or skip patterns that need to be, skipped. We can have those overrides, but it needs to be requested and approved. And all this would have an audit trail, so we would know how many changes have been made, how many overrides have been requested, so that we can try and see, and maybe there needs to be a change in some of the rules. We also have shipment tracking and receipt that will help us close the loop and make sure that the specimens that have been sent was received by the lab, Jennifer, and then be able to, or other lab, and be able to check and see if the conditions are good for analysis. Next slide, please. We also have email alerts as feature of this data entry system, and especially since we're going to be doing screening, and we want a quick turnaround on the screening results so that you can talk to the parents to be able to enroll them in the biomarker study, main study. We would like to get the results out to you right away. So our plan is to have the lab upload the results of any of the specimens that have analyzed. And based on that upload, we're going to send out email alerts to all sites that have those specimens and give you the results of those that are positive, so you can focus on those subjects and enroll them into the study. And once you have successfully enrolled, we also send out email alerts to make sure that you know that you have successfully enrolled, and then also the central unit would be able to be informed that we do have additional enrollments. Protocol deviations, we do have email alerts for those, just to make sure that, if there are any issues that are occurring a lot, that we can, focus on them and maybe discuss them with the sites. But these are the typical email alerts that we have for this particular study. Since this is not a clinical trial, we don't really have a lot safety alerts, but which we typically have on other studies. As I've already mentioned, monthly reports, we send out monthly reports so that we can figure out if there are any missing visits or any forms that are pending that have been saved but not locked. So that helps us keep track of the data that are the data, as well as the implementation of the protocol for each of the sites. Next slide, please. And as I've already mentioned, really the screening and an enrollment for this particular study, basically what's going to happen, and you're going to see this when we give you the training and the data entry system, there will be like 2 phases for those who are screened, because there are 3 groups that we're going to be enrolling, actually 2 enroll, the other one is more of a control. For the screened patients, there will be 2 stages. There's the screening. Once they get positive result, then they can enroll. But for those that are referrals, then they go straight to enrollment. So this is just for screening, and a lot of you are probably on the 0095. We're trying to do a similar system that they have there, that you had with MS, where we do a barcoding reading so that you don't have to type in all the labels, and then that would help minimize any mistakes in entering the data. And that would make it easier for you guys to enter and send the shipment to the lab, and the lab will also be able to just match the barcodes to the results that will be emailed to you, as mentioned in the previous slide. Next slide, please. So we will be contacting you for training. It'll be probably an hour of Zoom, and it will be recorded so that some people who might not be able to attend will be able to view it, and for future new coordinators will be able to do it. But we can also provide non-recorded training, new training, but probably that needs to be scheduled properly so that it's not all the time that we have available, but at least there's the recording just in case somebody needs a refresher or would need training right away. We don't have randomization here. So it's really screening and enrollment, case report forms, key elements of the data entry system that you need to know us, how to navigate from one visit to another, how to find some of these forms that are not associated with scheduled visits. And we need to have that training done prior to activation of the site. You cannot enroll. Pretty much the data entry system training and certification is like the last gate that you have to pass by before you can enroll a patient. So as much as possible, we want the training to be just before you get yourself approved so that it's still fresh in your mind. And then after that, when you can enroll, instead of getting too early and then you forget and then have to have a refresher. So prior to activation is the ideal timing for the data entry system. So I've said entering data, coordinators, and if PIs want to enter data, then they also need to be able to get training for EDS. Next slide, please. So, and this again will be in the training. There are different modes, and the reason why I just want to mention this one is just to keep in mind that each of this mode would actually be serving different purpose. Test mode is just to play around with the data entry system. Certification is where you actually put in your certification data so that we can grade it and we can tell you you passed or did not pass. The production mode is actually the enrollment. So it is important to make note that these are different links, and we're the one controlling it. We can only give you one of this, and it's going to be important for you to know which one you have, because you might think that you have production when you're actually doing a test or certification, then whatever you enter is not going to be valid because they're not in the production mode. So things like this would be given to you more in detail when you do the training, but I just want to make sure that that everyone's aware that there are different modes, and you only get to have one mode, and it's usually in this sequence, which is the beta, which is where you do the play around, getting to know the EDS, the certification telling us we're ready to test. And then once you get past certification, we give you production, say you're ready to enroll. And then the group access, you can either again have a CRF data entry account, which means that you're going to be entering the data into the EDS, or and this is what some of the PIs have, is just the view only. They can view the data, but they cannot enter the data. So the view only would not really need any training, but you cannot enter the data, but you can just view them. Okay, next slide, please. So steps after the training. So I've said after the training, you're given a chance to practice, and then you're going to do certification, and then you're going to be ready for enrollment. Again, the ready for enrollment, hopefully the certification and all this would be just before you're able to enroll, so that you don't have to keep getting a refresher course because it's been a while since you had the training and certification. Next slide, please. Okay, and finally, so I've said the training will be recorded so that those who aren't able to attend may be able to follow with the training and get the training. Any new team member after initial training and sign up must receive EDS training and be certified as well. And I've already said this one, training must be done as close as possible to activation. I think that's it. Thank you.
Any questions for Chi Chi regarding the EDS system? Like I said, recognize it again, that you guys will be receiving, the additional training through the, on the EDS system from her group. Any questions? I know a lot of you, if you've participated in some of our older BAA studies, you're going to be very familiar with the system. It's going to be similar. It is a prettier platform. It's laid out a little bit different, but the functionality is pretty much the same. All right. And so these are the slides that you're seeing now, hopefully you're seeing it now, is our contacts for all of us here that are basically presented on this call today, on this training today. We've got our names and what our basic roles are. I know if you're new to the central unit, you may not understand that Jennifer handles the lab, Miss is doing the, the Bopana lab, Susan and Tina is doing regulatory. So we provided this here for you in just kind of a snapshot format. The good thing about it is we all play well together. So if you have accidentally send me a regulatory, I tell Susan all the time, and I'm Jill, and I handle clinical. So if I get something regulatory, I say, I don't play in your sandbox. So I give it to Susan for her to handle. So if you get the wrong person, it's okay. We make sure it gets to the right home. Any questions from anybody regarding anything that we went over today? Anything, David, you want to say as a wrap?
Yeah, I want to thank everybody. This is a great opportunity, and I really think that we have a chance through this study to significantly advance the field. I mean, more than honestly, just even a single treatment study, because what we do here has the potential of informing how future studies are developed for decades to come. And so I really want to thank you for your diligence as you get underway with this. And we look forward to working and partnering with you on it. I think that when we get to the end and all of us, have ownership of these data, I think we're going to be able to walk away and feel that we've done a really good job and something that accomplished something that will be meaningful. And that's why we're doing this. That's why we're in the game. So thank you for you and for your teams for what all you're doing. And we look forward to getting moving with this. Absolutely. And we've got a question in the chat. Was this session recorded? Dr. Storch, we surely hope so. We pushed the record button, and like last time we did that, I accidentally didn't save it. So I'm hoping that it's flashing right now, telling me it's being recorded. So I'm hoping that is indeed the case. And we will post it once we get the website up and going, the study website, what Chi Chi was referring to earlier, the document library. We will post a link to this recording. We've got to get it converted to a smaller format, like a YouTube format. So our IT will help us get that done. We will get it posted along with a copy of the slides that we've gone over today. So that if you have any additional staff that comes on, unfortunately for this invite, I only had the PI's names and email addresses because I didn't know your study team. So this goes back to what Susan was saying, having that study contact form is so important because it helps me to us to know who to communicate with. So I was only able to invite PIs, and I said share with your team. But going forward, once we get that contact form and we get access to everybody for the document library on the website, you will have access to these slides and this recording. Any other questions for us? And again, you're on mute, so unmute if you want to speak, or you can put it in the chat box. All right, well, we're going to give you guys back a little bit of your day. So thank you so much for participating in our site study startup call. We definitely appreciate your time, and we're looking forward to working with each and every one of you. Again, you've got our contact information here on the slide. Should you have any questions regarding anything presented today or anything that wasn't presented that you wanted to know a little bit more about, please feel free to reach out to the appropriate individuals. And like I said, again, if it happens to go to the wrong person, we'll get it to the right person. So thank you guys. You guys have a great day. Take care.
Bye, thank you.
All right, bye-bye.
All right, Jill, before you close out, make sure you do whatever you said for me to tell you to do.
Stop sharing first, maybe.
Yeah, stop sharing. Still recording also.